Thank you very much, Dr. Conley. I'd like to also thank John and Jocelyn and Annie and Sarah and Claire and Megan and Matthew and David, and I'm probably missing a couple, but you've done a terrific job. I want to reiterate Dean Dunlay's comments of this morning. I've really learned a lot. I've really enjoyed being here, and I hope you've learned something as well, but thank you very much for having me. All right, let's get to the slides, and because I have a mobile mic, I'm going to wiggle around the stage a little bit. So, we're going to talk about outbreaks. Before we do that, let's get a little background. How many of you have survived a pandemic? I'm just curious. Anybody? Terrific. The rest of you were born after 2009? Or you're zombies, right? So those are your two choices. We had a pandemic in 2009. You may have slept through it. It was H1N1. We'll talk about it a little bit farther on. And we'll talk a little bit about why you probably didn't care about it. But let me tell you that the mortality rate of that pandemic in the United States was 0.002%. Works out to about 12,000 deaths. If that mortality rate had been 2.5%, which was the mortality rate of the Spanish influenza, also an H1N1 virus, in 1918, that would have been 1.36 million deaths in the United States. If that mortality rate was 59%, which is the mortality rate right now of H5N1, which has been circulating in Southeast Asia and avian influenza since 2003, that would have worked out to, in the United States alone, 36 million deaths. So you probably would have realized that you had been in a pandemic at that point. So outbreaks happen. It's unlikely that President Obama is ever going to get on national television and say, we need to talk about histology, right? But he did do this with Ebola. And so when outbreaks happen, they sometimes get the world's attention. And we're going to try and figure out a little bit over the next half hour, 40 minutes or so, why did Ebola happen and why do these things kind of happen? And then when they do happen, how do we recognize them and how do we try to contain them so you don't get this situation where you end up with 22,000 cases, almost 9,000 deaths. 99.8% of the cases and deaths are in these three countries. And what you probably didn't realize was there was actually a separate Ebola outbreak in the Democratic Republic of Congo this past summer that was contained, because you were too busy hearing about this one, and all of Ebola outbreaks are kind of lumped together. So we're going to run through some of those issues. So as Professor Ryan mentioned yesterday, it's always great to start with definitions, so we'll start with some definitions. We'll talk a little bit about why President Obama and governments care about outbreaks, and it's not because people die, even though that's what they say. And then we'll talk a little bit about how do we try to do something about it. So, when you have a knotty problem in the United States that has to do with health sciences, you go to the Institute of Medicine. The Institute of Medicine is our collection of our best and brightest health scientists, researchers, and practitioners. And in 1992, they were grappling with emerging infections and asked to come up with a definition of emerging infectious diseases. And what they came up with is emerging infectious diseases are infectious diseases that are emerging or could emerge. Now, it's kind of hard to believe that it took our best scientists to come up with that, but they did. And so now at least we're all on the same ground as to what we're talking about. How many of you have been to Disney World? It's okay, don't be embarrassed, I've been there. Okay, a lot more than survived the pandemic, I see, that's pretty cool. All right, so if you've been to Disney World, you realize that they have a theme every year, like Mickey Mouse is 100 years old, or Donald Duck got pants, or something. Every year they have a reason to celebrate. Well, the World Health Organization does exactly the same thing. They have a theme every year on World Health Day. Does anybody know what this year's theme is? All our global healthy people? So it's vector-borne diseases. Don't get bit unless it's by someone you love. And next year, if you want to jump on 2015, it's going to be food-borne illness and food safety. So if you want to impress your friends, you can say, well, hey, did you know the World Health theme this year is going to be food safety? And well, probably won't. But in 2007, it was on international health security. That's the cool thing about global health. Global health has a lot of completely random but cool facts. And I'm going to throw some out during the talk that you can go into a bar and like drop on someone and I don't know, maybe you'll make a new friend or something like that. So here we are. Basically what the World Health Organization in 2007 is we have all these new diseases emerging, and basically it's happening because we're screwing up the world, right? They don't quite put it that way, but that's fundamentally what they mean, and this is going to continue as we continue to screw up the world. So, as Tom pointed out this morning in a really beautiful and elegant talk, the power of data. So the first thing we want is we want some data, and we want to know, are emerging diseases in fact emerging? And so here's a study that was published in Nature in 2008. And basically what we're looking at, and we can probably do this a little easier with the mouse, is so these are different kinds of infections by the organism or pathogen. This is whether or not they're zoonotic. And zoonotic means it comes from an animal, okay? And then over here is drug resistance, non-drug resistance down here. And then this is vector-borne or non-vector-borne, which is this year's theme. And the only thing you have to remember here is that about 2/3 of all the emerging diseases are actually coming from animals. So these are diseases that start in animals, they belong in animals, and they jump a species barrier, they get into humans, and then they cause problems, at least for us. So I want to take you through 3 kinds of emerging diseases. And the first one's way up here. This is parvovirus B19. Well, this is 5th disease, okay? So this is one of the childhood fever rash diseases. And doctors have known that this has been an infectious disease for over 100 years, okay? And so why is it up here? It's because in 1975, we developed the technology to isolate this virus and figure out that 5th disease is in fact caused by parvovirus. So that's one of the, quote, causes of emerging diseases, is that we just have better tests today. And as we have better tests and we apply these tests, we find things. And so that's one cause. The second cause is down here on the left, and this is Helicobacter pylori. When I was a medical student way back in the 1980s, peptic ulcer disease was caused by cigarette smoking, stress, caffeine, and alcohol. And what we did, much to the delight of GlaxoSmithKline, which was SmithKline Beecham back then, is we put him on a medicine called cimetidine and said, you're going to have to take this medicine for the rest of your life. Lo and behold, these 2 Australians, paying no attention to the fact of how the rest of us were doing modern medicine, said, well, gee, maybe this is actually caused by a bacterium, because if you read these papers from the 1920s, pathologists were talking about bacteria in the stomach. And the rest of us who knew much more than Australians were saying, what are you, nuts? The stomach is all full of acid. No way bacteria could live there. So Barry Marshall and Robert Warren persisted on, and lo and behold, they isolated this bacterium that they called Campylobacter pylori, and they published this, and the rest of the world said, you're stupid, and now we're going to go out and prove that you're stupid. And what did they do? They proved, in fact, that they were correct. And for their trouble, they eventually got the Nobel Prize in medicine. But so this is another emerging disease, a disease that we always thought was caused by something else, but that we in fact learned is caused by an infection. And then the last group is best described by human immunodeficiency virus. So this is a simian virus. This is a chimpanzee great ape virus that somehow in the 1920s or 30s managed to jump a species barrier from chimpanzees into humans and then disseminate. And that's usually what we're thinking about when we talk about emerging diseases. SARS would be another example. That's a coronavirus, originally a virus of bats, got into civet cats, and got into people, and then got around the world. So those are the ones that we're going to focus on for the rest of the talk. Now, what I want you to do is focus down here. We think of emerging diseases as a new problem, but if you look at, these are real small numbers to read, but this is describing an outbreak of syphilis that occurred in 1494. And does anybody know why syphilis was described first actually in Italy in 1493? It's because it never existed in the Eastern Hemisphere. Yaws was endemic in South America, and what happened in 1492 is Columbus and his buddies got on a boat. They go doot, 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 doot over here, and they met the native women, and they did what sailors do after they've been on boats for a long time with native women, and then they came boop, 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 boop back, and they brought back things like tobacco and eventually gold and other things. But one of the things they brought back, which they didn't mean to, was syphilis. And then syphilis got introduced, but they left measles behind, so you can decide whether or not that's a fair trade. And so syphilis then disseminated all around Europe, became known as the great pox. The reason why smallpox is called smallpox is because syphilis was the great pox, okay? Well, the Mongols did the same thing. They picked up Yersinia pestis as they were passing through Central Asia, and they brought it all the way through here in the 1300s. And so the point of this is, while we think of emerging diseases as a modern problem, in fact, we've been moving pathogens around the world for a long time. The other take-home message from this slide, which will come up again later in the talk, is nothing ever happens in New Zealand. Look at any slide about bad things happening around the world, and there's never a dot in New Zealand. And I don't know why that is. Maybe it's because sheep outnumber people, like by 1,000,000 to 1 or whatever it is. But look at these slides. You will never see a dot in New Zealand. So why do we care about these things? Why does President Obama talk about it? Why does the World Health focus on them? They cost a whole lot of money. Okay? So this is SARS, $30 to $50 billion. There were 799 deaths from SARS between November of 2002 and June of 2003 when they had SARS outbreak. 799 deaths. To put that in perspective, that's the same number of deaths we have in LA County every 5 days. Can you imagine if we lost $50 billion in LA County in economic output every 5 days? So what happened? What happened here, and what you're seeing with Ebola, is that dealing with outbreaks is really fundamentally about managing fear and panic, okay? Yes, you're dealing with a pathogen, but almost always in these situations, the pathogen is almost the least of your problem. And it's really trying to deal with misinformation and fear and panic that results in these kinds of huge economic losses, right? Just think of all of the preparations and news detail that has been devoted to Ebola in the United States that has had 4 cases, 1 death. And then you start to get a sense of how these things can have huge economic consequences, and that scares the heck out of governments, and that's why they care about these things. So why do they happen? So there are a whole bunch of things going on. One is we don't live alone on this planet. We tend to think we do sometimes, but we actually share it with lots of other organisms, and they also adapt to what we do to the planet. So they're not static, just like we're not static. We have environment, economic consequences. The talk this morning was really lovely about describing some of the economic issues around health. And then there's all these other kinds of things that happen as well. So what are some of the data? So again, we're going to go back in time. This is Panama. This says Yellow Jack. You got a skull here. Here's Teddy Roosevelt and Uncle Sam, okay? And what are they talking about? They're talking about building the Panama Canal, because there's a 47-mile stretch between the Pacific Ocean and the Atlantic Ocean if you can happen to get through Panama. Well, the French tried to do that in 1881 to 1899, and they ended up having 22,000 people. About half their workforce died between yellow fever and malaria. And so that's what's up here with Yellow Jack. So the Americans, Ronald Ross had recently discovered that malaria had been transmitted by mosquitoes. A guy named Gorgas, a colonel in the U.S. Medical Army Corps in Havana, had managed to eliminate yellow fever from Cuba using mosquito control. And so Gorgas and his colleagues came down to Panama, and they basically applied mosquito control techniques and were able to have a tenfold reduction in malaria deaths, eliminate yellow fever, and they were able to build, they did personally, but lots of laborers were able to build the Panama Canal because they were going into an environment where people normally didn't live that much, but mosquitoes lived a lot. And so by going in and putting people in an environment where they hadn't been before, they were exposed to a whole range of diseases. As an infectious disease physician, I would suggest to you that if you own a camel, you do not exchange bodily fluids with your camel, because it so happens that camels have a coronavirus that you can find in their breast milk, in their blood, in their meat, that they do just fine with. As far as we know, this coronavirus causes no disease in camels, but when this coronavirus gets out of camels and into people, as occurred starting in 2013, we get this problem known as Middle East Respiratory Syndrome coronavirus, or MERS. We've had almost 1,000 cases, about a 30% mortality rate since it was first described. And there are probably lots and lots of these kinds of infections in animals. We just don't know about it. So how does this all come together? And so to bring it all together, we're going to talk about the Nipah virus. So this is a bat, or a flying fox. So here's one of those fun facts to impress your friends at a dinner party. 1 in every 4 to 5 mammalian species on the planet is a bat. Okay, so there are over 1,000 described species of bats. So there are lots of them out there. We tend not to think about them. These guys are quite large. They live in the jungles of Malaysia. They want nothing to do with people. They just want to be left alone. They can fly around trees and eat their fruit. Well, what happens as the population grows here in Singapore and Malaysia is you need some place to raise your pigs. So what do? You go out into the jungle, you mow down all the trees, you build a pig farm. Okay, all fine and good. You decide you want to supplement your income, so you plant some mango trees around the pig farm. Unfortunately, you now have displaced the fruit bats, which were living up here fine and dandy, and they now have no place else to go, and they have no more fruit trees because you've mowed them all down to build your pig farm. So they come and they start eating on your mangoes around the pig farm. When that happens and they defecate, the mangoes and the bat stool gets eaten by the pigs, because pigs are pretty omnivorous creatures. They'll eat just about anything. And unfortunately for the pigs, Nipah virus is endemic in fruit bats. Again, they do just fine. Doesn't cause them any problems at all. But when it gets into pigs, you get what's called a barking pig. I have never heard a pig bark. I have no interest in hearing a pig bark. But when they do bark, it means, in Malaysia at least, that they probably have Nipah virus. So then these pigs are transmitting Nipah virus from pig to pig. It then goes from pigs to people, and you get an outbreak of encephalitis, high mortality rates associated with that. How did they stop this outbreak? They basically slaughtered all those pigs, and they interrupted that chain of transmission. What else do we do? We move used tires all around the world. I have no idea why we move used tires around the world, but we do. And when we do, they often have little puddles of water in them. And inside those are larvae for this beauty. This is Aedes alopeficus. This is the East Asian tiger mosquito. And I'm sorry to say, ladies in the audience, this is the one example where it is the female of the species that's creating all the problems, not the male. So, male mosquitoes are vegetarians. They don't bite people. It's only females because females need to take a blood meal in order to ovulate. So the female has to feed on blood to be able to ovulate, and when she does that, she can transmit diseases. Aedes alopeficus and Aedes aegypti are terrific vectors for viral infections like dengue. And so what's happened is, as we've disseminated these tires around the world, globally across tropical parts of the world, we have disseminated this viral vector. Dengue fever is now the most common cause of hemorrhagic fever worldwide. It's estimated about 1/3 of the population is potentially at risk now for acquiring dengue fever. There have been outbreaks in Hawaii, as known here, and we had an outbreak a couple of years ago in Key West as well, because this mosquito happens to live there now in Key West. So, one of the consequences of technology is we can now get around the world in the incubation period of any infectious disease. So you can get on a plane in Omaha feeling totally healthy, get off a plane pretty much anywhere else in the world, still be healthy, and then get sick. And that has real challenges for trying to prevent the spread of infectious diseases around the world. So let's take one example of this, West Nile virus. So this is an RNA virus, a flavivirus, includes Japanese encephalitis serocomplex, first described in 1937 in Uganda. And the first cases occurred in August of 1999 in Queens, New York. Well, most of us, even though we are geographically challenged here in the United States, realize that even the western part of the Nile River is probably nowhere near Queens, New York. So the question is, how did it get there? So, to understand that, we have to go back in time to the summer of 1909, and we have to deal with these beautiful birds. This is the American crow. And the summer of 1999, in New York City, crows are dying left and right. They're just falling out of trees. Well, New Yorkers are a pretty jaded bunch, and so they're just kind of stepping over the dead crows. Oh, yeah, dead crow, you know. Mom's going out to play, bringing umbrellas, raining dead crows. Right? But nobody's asking the question, why are the crows dying? Because crows are somewhat unusual among the bird families. They're very social birds. You've probably seen this. They get together in really large groups of trees, usually about 5 o'clock in the morning, and they start making a racket, right? And say, oh yeah, catch a dead squirrel over on Fifth Street down, all over the backyard, we're there, blah, 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 right? And so people are probably glad that the crows are dying. So it's like, thank God, yeah, get rid of the suckers. Who cares? You know? And over in Queens, New York, 2 elderly gentlemen come down with encephalitis and die. A very astute infectious disease physician contacts the public health department. She said, gee, I'm kind of worried. We may be having an outbreak. It's unusual for me to see 2 cases of encephalitis in such a short time period. The public health department says, well, we might be having an outbreak of Eastern equine. Maybe we should do something about it, but that's really about all they do. Meanwhile, over in the Bronx, you got the Bronx Zoo. And in the Bronx Zoo, you have these beautiful Chilean flamingos. And in the summer of 1999, the Chilean flamingos are keeling over and dying. And unlike crows and old people, when Chilean flamingos die, somebody wants to know why. And so they do necropsies on these Chilean flamingos, and they find that they die of overwhelming viral infection. But they don't stop there. They isolate the virus. They see it's some kind of a flavivirus. They think initially it's an Eastern equine, but they don't even stop there. They then send these viral cultures down to the US CDC to do whole genome sequencing. This is 1999. You can get whole genome sequencing today in Burger King, right? Like gives you a burger. But in 1999, this was actually a really big deal. And they found that it was West Nile virus. And they're like, how the heck did West Nile virus get in our Chilean flamingos in the Bronx Zoo? Okay? And not only is it West Nile virus, but it's a 98% homology with an Israeli goose West Nile virus isolated the year before by the Pasteur Institute. And so all these really smart people are saying, aha, we figured it out. Israeli geese, which have been migrating between Europe and Africa for eons, made a wrong turn, came across the Atlantic, and landed in Queens. Without anybody knowing that they got there. Right? And if you've ever flown from Los Angeles to New York, and New York to Los Angeles, you know that it's actually shorter to go from Los Angeles to New York than New York to Los Angeles, because the winds blow. Prevailing winds blow from west to east in the northern hemisphere. So you would think if they were blown off course, they would have ended up in Siberia instead of Queens. And so that was a kind of a puzzle, and they're trying to figure it out. But where were the first cases in the Western Hemisphere? They were in Queens. And so you start to think about what else is in Queens. Well, JFK Airport happens to be in Queens, New York. And it turns out that in the summer of 1999, there was an outbreak of West Nile virus going on in Tel Aviv, in Israel. And every single day, a 747 takes off from Tel Aviv and lands in Queens, New York, at JFK Airport. And they said, aha, we figured this out. The Israeli goose got his passport, put on some glasses, got on the plane, ended up in Queens. And that's probably what happened, but it wasn't a goose, right? It was probably a person or many people. We don't know this. This is a hypothesis. But what we do know is that only about 1 in 150 persons is actually sick from West Nile infection. The other 149 feel totally fine, despite the fact that they can have very high viremias and potentially be contagious. Infectious rather than contagious. So what probably happened is someone who was viremic came off, or a bunch of people, got introduced into the mosquito population, got amplified among crows. Unfortunately for crows, it's fatal for them. And then from there, disseminated outward and upward. So this is what happens when you introduce a new infection into a susceptible population. Right? So it took about 5 years to take a virus that had never existed in the Western Hemisphere before and to disseminate. It is now endemic. You probably have learned about West Nile virus, or you will here at Creighton Medical School. It will never go away. We will never be able to eradicate this virus from the Western Hemisphere. So when do we get concerned about these kinds of outbreaks? We get worried when they're unknown. We get worried when they spread. We really get worried when they mess with our money. And we get worried when they're attacked. So what do we do about it? So we changed the rules in 2005. So before 2005, there were only 3 reportable diseases. There were cholera, plague, and yellow fever. Those were the only things you actually had to legally, as a country, you legally were obliged to tell the World Health Organization about. And even then, the World Health Organization didn't have any mechanism for enforcing that. Well, SARS scared the heck out of everybody. So as a result of SARS in 2003, they had a new meeting. They changed the rules by all 194 countries at the time, went into effect in 2007. And so now, instead of specifying the diseases, it's just any medical condition, irrespective of origin or source, that could be a significant harm to humans. So you can see that's pretty broad. It covers a lot of possibilities. And there is now a legal obligation to notify the World Health Organization of public health emergencies of international concern. And there's a legal obligation to develop a minimal core public health capacity. We'll come back to that when we talk about Ebola in the next session. So how does this all work? So let's go back to that pandemic that you slept through and you didn't realize happened in 2009. Here we are, H1N1. And in March and April of 2009, there's this outbreak of acute respiratory illness in Veracruz, Mexico. Very astute clinicians. So even if you never go into public health, you have a role in outbreak detection. Almost all outbreaks that have been found because some healthcare worker, doctor, nurse, whoever, said, gee, this isn't right. I'm seeing something I don't expect to see. And when that happens, little flags should go off in your head. You should think about notifying somebody. So some astute physicians recognized they were seeing respiratory illnesses in otherwise young, healthy people. And they shouldn't be seeing that. So they said, something's going on. April 21st, the CDC isolates a brand new H1N1 from Southern California. That sends off all kinds of alarm because influenza A's are the only influenzas that have pandemic potential. So when you see a new influenza A, you get really, really worried about that. So what happens? Mexico did everything right. Everything right. So they had a national pandemic preparedness plan already in place because of SARS. After SARS, every country tried to do this. And they basically shut down a city of 20 million people. And think of what it means to close a city of 20 million people. But they did it. And they notified the World Health Organization on April 25th. WHO declares H1N1 to be a public health emergency of international concern. By June 11th, we are on pandemic level 6, which is the highest level you can be for a pandemic. So we're doing everything we can to contain this. So how did we do? Here we are on April 27th. What happens? Right? So this virus just takes off, despite the fact that we did everything right. Why is that? Well, if you look at travel between the United States and Mexico in March and April of 2008, almost 2 million people are moving between the United States and Mexico in those 2 months alone. And what you're seeing here is travel between Mexico and these countries. These are the 20 most common countries in terms of number of people who traveled from Mexico in March and April of 2008. This is whether or not they got imported H1N1 in 2009. 92% sensitivity and specificity. We're just moving all around the world all the time. And it's not just us, it's food, it's people, and so very difficult to contain these kinds of outbreaks once they occur. So let's turn to influenza for 1 minute before we wrap this all up. And so nobody seems to be panicking about influenza that I can tell. The week of January 17th, it was estimated by the CDC that almost 10% of all deaths in the entire country that week, which works out to about 4,500 deaths, were due to pneumonia and influenza. We've had 56 deaths in pediatric deaths from influenza this year so far, and this is the really scary number. So it's H2N3. So influenza vaccines have 4 components to them. They have 2 influenza A's and 2 influenza B's. Unless they're trivalent, then it's 2 influenza A's and 1 influenza B. But it's the second influenza A, the H2N3, that's causing most of the problems this year. It's not a good match with the vaccine, unfortunately. And as you can see, we're having disseminated influenza spread this year. It's been a pretty bad year for influenza. Yet we didn't call out the National Guard or freak out or anything else. You can kind of wonder why we get all worried when one person dies, but we don't get worried when 4,500 people die in 1 single week. So why do they occur? They occur because we're better at finding them. They occur because we're changing the environment and we're moving very rapidly all around the world. So what do we do about it? This is an epidemic curve for an outbreak of salmonella-contaminated peanut butter. So these gray lines are cases of foodborne poisoning from salmonella contained in peanut butter. Starts somewhere around September, October of 2008, ends February of 2009. This line is where the US CDC recognized something was wrong. This is where they figured out that its salmonella contained peanut butter. They stopped the sale and make a public announcement. And these are Google searches. So at any given time, there are people out there Googling diarrhea. Go figure. So, all right, maybe you've done that. And maybe you have Googled peanut butter. But you probably haven't Googled the two together very often, right? So here we are, we're Googling peanut butter, we're Googling diarrhea, we're Googling food poisoning, we're Googling salmonella, we're kind of going along. And our outbreak is happening. And what's happening? Google searches for diarrhea start going up, 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 up. Google searches for food poisoning start going up, up, up. And even Google searches for peanut butter start going up. So people have figured out, damn, I'm sick, I got diarrhea, and it's probably the peanut butter. So the question is, can we somehow capture that collective data in a way to recognize outbreaks sooner? And that's fundamentally what all the new technology is about. It's basically around trying to use what's called big data to learn faster about outbreaks. There are a whole bunch of different organizations and groups, including ProMedMail, that Dr. Townley mentioned about trying to do that. And then you can see the announcement, and there are these huge spikes afterward about the announcement. But that's fundamentally what we're trying to do. We're trying to use what's called informal information to recognize outbreaks. Why do we want to do that? Because maybe we'll find them faster, and we can respond sooner, and we can prevent governments from covering them up. So the Chinese government knew about SARS in the fall of 2002, but they didn't tell anybody about SARS. And it wasn't until February of 2003 that there was an announcement. And actually, ProMedMail was the first to globally announce that there may be an outbreak going on in Guangdong province in China. And so, since that time, part of the international health regulations change in 2005 was this legal requirement to notify the World Health Organization if something's going on. What are the challenges? There's just way too much information out there. So I learned that there are over 500 million tweets every single day. I'm proud to say I have yet to contribute one to that 500 million, but those of you out there are probably contributing some of them. Another problem is that it's very hard to know what information to believe. There are lots of different systems, as I showed you. They don't talk to each other. And who do you let know about it? So those are some of the challenges with trying to do this. Here we are again. Nothing in New Zealand. Go figure. Okay. So this is some research that we did. We basically took about 400 WHO verified outbreaks over roughly a 13-year time period. We mapped them all out, and we tried to understand, does informal information help us recognize these outbreaks sooner? And you can see, at least when we did this study for that time period, on average it took about 23 days to figure out there was a problem, 32 days to report it, 35 days to actually confirm what was causing the problem, and 48 days for the WHO to put out an announcement. These are hazard ratios, but basically just focus at the trend. You can see we are getting faster over time. So we are recognizing outbreaks sooner. So one of the things that we learned from that study is, yes, we are probably raising warning signals sooner, but is it because of informal information? We didn't know. So our next study, we actually tried to break it out from informal sources, which just basically means anything other than public health laboratories and hospitals. So you can see that over time, public health laboratories and hospitals have gotten faster at recognizing and reporting these blogs, tweets, news sources, other informal sources have gotten faster over time. But on average, these tend to pick things up about 10 days before these. So if you look at the scales, you're going from about 50 down to about 30, and you're going from 60 somewhere into 30-20. But it turns out on average, these are a little bit quicker than these. but these are obviously much more reliable. There's going to be more false signals in the informal side. So they are making a very real contribution. Where are we trying to go in the future with this? Basically, we're trying to figure out how we can use all kinds of information that is being collected without you even knowing. So I actually have 2 cell phones on me right now. These are, in fact, computers, and they can measure my body temperature. There was a study that was done by the University of Iowa, which I learned. I'm so pleased that I learned this. You actually have to go through Iowa to get here. Anyway, these things have a thermometer in them, because if your phone overheats, it doesn't work. So what these very clever guys, men and women at the University of Iowa did, is they got a study. How they got this through human subjects, I don't know. But they basically got a study where they got permission from Verizon and AT&T and everybody else to record your temperature as you're walking around on your cell phone. Because buried in that long line of terms and agreements was a line that says, oh, and we allow the University of Iowa to check your temperature. And of course, you didn't bother to read that. You just said, oh yeah, I accept terms and agreements. Yep. And so, lo and behold, they did it. And what they were able to do with that was they were basically able to demonstrate that just by tracking where cell phones go, you could tell who was out sick. Because basically your cell phone follows you through your normal day, and if you don't follow your normal pattern, it's usually because something is wrong or something's happening. So very, very interesting study. You can do lots of things like that to basically try to aggregate what you know about diseases, where they should be, where you think they might not be, throw in environmental and social conditions, and at the end of the day, try to predict where outbreaks are going to happen. That's really sort of the goal, the pot of gold at the end of the rainbow is not can we react to an outbreak quickly, but can we actually try to figure out where they might happen before they happen and prevent them from happening. So that's where we hope to be one day. We're clearly not there yet, but we're working on it. Just to summarize this last part, yes, the majority of all information now about outbreaks does come from these informal sources. They are a little bit faster. They're a little less accurate. We still got to work on coordination. They may help with preventing government suppression of information. Here are some of the people who actually help do all the research, including, these are all based at ProMed Mail, which is totally free. It's like the police scanner of the ID emerging disease world. So if you're into listening to police scanners, sign up for ProMed Mail, and you can learn all about outbreaks as they happen around the world. Some colleagues of mine, when I was at McGill University, and then a group at Harvard, we had some money from Google and NIH to do that. I'd like to thank you very much for your attention, and I would be delighted to answer any questions. Thank you.